The cause of death was listed as an accidental drug overdose. The medical examiner disagreed, uncovering toxic drug levels detected in the deceased system that exceeded standard lethal limits by a considerable margin. Initial reports suggested isolated recreational use, but the post-mortem examination revealed multiple sources of illicit substances, including opioids and stimulants. A thorough investigation into the deceased's history uncovered patterns of chronic substance abuse, which had not been previously documented or addressed in medical records. The toxicology report indicated a cocktail of drugs ingested simultaneously, significantly complicating the picture of the fatal incident beyond initial assumptions. This case underscores the complexity involved in establishing definitive causation when toxic drug levels are detected in overdose fatalities. Chapter: Case Background. The incident under investigation occurred on March 15th at a residential address located in downtown Philadelphia, Pennsylvania. At approximately 10:30 p.m., local emergency services received an anonymous call reporting a medical emergency at the specified location. Upon arrival, paramedics found the deceased lying unresponsive on the living room floor, with signs of recent consumption of substances. Initial observations indicated that the individual was conscious, but in severe distress, exhibiting symptoms such as rapid breathing, dilated pupils, and erratic behavior before becoming unresponsive. The caller reported witnessing the deceased ingesting a substance shortly before losing consciousness. No other individuals were present at the scene during the emergency services' arrival. The initial assumption was an overdose due to drug use or possible alcohol poisoning. After unsuccessful resuscitation efforts, the paramedics transported the deceased to a nearby hospital where they were pronounced dead upon admission. The medical examiner's office was notified and conducted an autopsy to determine the cause of death. Toxicological tests were ordered to analyze potential substances ingested by the deceased. Chapter: Initial findings upon arrival at the residence. First responders observed the deceased lying supine on a bedroom floor, surrounded by scattered medication bottles and empty containers. The body position suggested no signs of forced entry or struggle, consistent with a scenario of accidental ingestion rather than homicide or suicide. Visible injuries were absent. However, pallor and cyanosis around the lips indicated possible respiratory distress prior to death. Initial medical assessment documented pinpoint pupils, indicative of opioid overdose. Cardiopulmonary resuscitation was initiated, but found to be ineffective due to lack of responsiveness and absence of spontaneous breathing. The scene conditions indicated a controlled environment with no signs of recent drug use, except for scattered paraphernalia associated with substance abuse. Given the presence of multiple pill bottles with labels bearing various psychoactive substances, including benzodiazepines and opioids, further investigation was triggered by suspicion of lethal toxic drug levels contributing to respiratory depression. The scene conditions indicated a controlled environment with no signs of recent drug use, except for scattered paraphernalia associated with substance abuse. This scenario warranted immediate forensic toxicology analysis to confirm causative agents in the deceased system. Chapter: Forensic investigation. Upon arrival at the residence, investigators secured the scene and initiated a thorough search for relevant physical evidence pertaining to the drug overdose investigation. The deceased was found in a reclined position on a living room couch with various pill bottles and loose tablets scattered nearby. A smartphone and several empty prescription medication containers were collected from the vicinity of the body. Notably absent were any paraphernalia associated with intravenous drug use, suggesting an oral ingestion route for the toxic substances detected. The chain of custody was meticulously documented, ensuring all items were sealed and labeled according to standard forensic procedures before being transported to the laboratory for analysis. The laboratory analysis commenced with a comprehensive toxicological screening to determine the presence and levels of various substances in the deceased system. Gas chromatography mass spectrometry, GCMS, was utilized for qualitative identification, while liquid chromatography tandem mass spectrometry, LCMS/MS, provided quantitative measurements of specific drugs and metabolites. Toxicological panels included opiates, benzodiazepines, stimulants, and ethanol. Detection thresholds were set at 1 ng/ml for opioids and 0.5 mg/L for ethanol to ensure accurate quantification. Tissue samples from the liver, brain, heart, and lungs were collected and analyzed separately due to differing pharmacokinetics. Histological examination revealed perivascular edema in the cerebrum consistent with acute drug toxicity. Microscopic analysis of liver tissue indicated signs of fatty change and microvesicular steatosis, indicative of drug-induced hepatotoxicity. Quantitative results identified fentanyl at 30 ng/ml and alprazolam at 15 mg/L, both surpassing established toxic thresholds for fatal overdose. The examination of forensic evidence established a detailed sequence of events leading to the deceased's fatal drug overdose. Toxicological analysis revealed elevated levels of multiple substances consistent with recreational use patterns. The postmortem interval was determined through entomological assessment, placing the time of death approximately 6 hours prior to discovery based on observed insect activity and known developmental stages of necrophilic insects present at the scene. The examination of forensic evidence established a detailed sequence of events leading to the deceased's fatal drug overdose. Toxicological analysis revealed elevated levels of multiple substances consistent with recreational use patterns. The timeline confirmed that the deceased ingested a combination of illicit drugs in the hours leading up to death, with no evidence supporting alternative causes of death. This sequence was corroborated by witness statements and electronic device analysis, which indicated recent drug purchases and communication patterns consistent with social drug use activities. The timeline also ruled out suicide as a possible cause, given the lack of suicidal ideation documented in the deceased's digital communications or personal writings. The forensic analysis revealed elevated levels of fentanyl and benzodiazepines in the deceased's bloodstream, indicative of a lethal drug overdose. Toxicological screens confirmed the presence of these substances at concentrations exceeding established toxic thresholds. Additionally, the absence of defensive injuries and the lack of evidence suggesting forced entry or struggle supports the conclusion that the ingestion was voluntary. While the precise sequence of events leading to the ingestion cannot be definitively determined from the physical evidence alone, the combination of toxicological findings and environmental context strongly suggests a scenario involving self-administration. Additionally, the absence of defensive injuries and the lack of evidence suggesting forced entry or struggle supports the conclusion that the ingestion was voluntary. Under oath, the expert would state that based on the toxicology report and scene investigation, it is highly probable that the deceased ingested these drugs voluntarily, resulting in fatal intoxication. Any uncertainty regarding the exact circumstances leading to ingestion would be acknowledged, emphasizing that the primary cause of death was undeniably drug toxicity. Chapter Resolution. The postmortem toxicology report has conclusively determined that the deceased succumbed to a lethal dose of fentanyl, a synthetic opioid approximately 100 times more potent than morphine by weight. Initial assessments had identified multiple substances in the system, including benzodiazepines and cocaine. However, it was the elevated levels of fentanyl that correlated with the acute respiratory failure observed at autopsy. Analysis revealed that the concentration of fentanyl exceeded therapeutic limits by a significant margin, consistent with an accidental or intentional overdose scenario. This finding necessitated reevaluation of the initial hypothesis centered on polydrug use as the primary cause of death. Confirmatory tests utilizing gas chromatography mass spectrometry, GCMS, validated the presence and quantity of fentanyl in both blood and urine samples. The toxicology findings coupled with clinical history provided by medical records indicating a recent prescription for pain management, but no documented issues related to benzodiazepine or cocaine use, shifted focus towards the misuse of prescribed medications. Confirmatory tests utilizing gas chromatography mass spectrometry, GCMS, validated the presence and quantity of fentanyl in both blood and urine samples. This shift underscores the importance of comprehensive drug screening and patient education on medication safety to prevent similar fatal outcomes in future cases. This investigation underscores the critical role of comprehensive toxicological analysis in determining cause and manner of death due to drug overdose. Precise quantification of substances within biological matrices guides conclusive forensic determinations, highlighting the necessity for rigorous analytical standards. The file remains open,